Everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters, and man, we have a great show for you.
What is happening, man? Welcome, and good morning. It is time for some Tuesday Training. Get excited because we're about to get wild with drugs today. Yes, everybody's going to get on drugs today. I can't wait. That's all we're going to talk about. And we've got some great stuff because we had some new stuff released regarding the Inflation Reduction Act just yesterday that we are going to dive into as well. Pretty big update. And I really can't wait to dive into this. I don't know if I want to say too much, but if you haven't been paying attention, the Inflation Reduction Act has made a pretty significant impact, or is going to make a significant impact on the Medicare Part D program. And a lot of us expected that it was going to actually increase cost, particularly in the side of premiums, deductibles, and so forth. And we're going to talk all about that. And based on the document that CMS dropped yesterday, that's exactly what happened. And so they have come behind with some new legislation, some new rules to try to stabilize that. So we're going to dive into all of that today. We have an amazing guest. I have Norma Johnson that is going to be with me today. Man, if you do not know Norma Johnson, you need to get to know her. If you are an agent in the Medicare space, she's certainly the most knowledgeable agent that I've met on the world of pharmaceuticals, right? The world of prescription drugs and so forth. She really understands that entire thing. She spent 20 years as a licensed pharmacist. She's been a licensed agent for, I believe, about 5 years now. And she is the founder of Strategies for RX Savings. Super excited to get her on the show. Get your questions ready because we're going to field them as we go through this stuff. So let's get her on. What is going on? Ms. Norma, how are you?
Good morning. I'm fantastic. How are you?
I am doing great. If I was doing any better, I'd probably be twins.
Well, just another active day in the Part D space, you know?
Yes, very, very much so. And I'm super excited to get you on. But before we dive into our topic, I know some of our viewers know who you are, right? They've seen you on stage talking about this before, but just take a moment, introduce yourself, and kind of give them a little bit of background on why you are the knowledgeable person to speak on this topic.
Well, I've been in the industry a long time. So I spent 22 years with CVS, been a licensed pharmacist since 2007, but I've been in the pharmacy since 2002. So, I've been entrenched in it. And of course, that doesn't always give you the Medicare perspective, but it does give you the pharmaceutical perspective. So, when it comes to understanding the system, I understand it well. When it comes to understanding the dynamics with the manufacturers, to the health plans, to the pharmacy benefit managers, their influence on pharmacies, the wholesalers, I get all of that stuff. And, that's the crazy thing is where I spent all those years in the pharmaceutical market and understand that background. Agents have just stayed on agents in Medicare itself has stayed on the surface. They never had to dive deep in because there wasn't a need, right? Everything was kind of focused on the plan. And there really wasn't a big focus on the Part D part. Right? Because we don't get paid that much. We don't get paid anywhere near what we need to be paid. Hopefully that'll change at some point. But, we haven't had to dive in. Now, unfortunately, or fortunately, I think it's a good thing because I think anytime you expand your knowledge, it's good. So now the agents are having to figure out what is Part D.
Yeah, from a much larger, broader perspective. Help us understand, I guess, the industry of pharmaceuticals in regards to how a drug kind of moves from the process from manufacturer through a PBM, through, I guess, the government carrier, all the way down to the person that's taking it hand to mouth. Like, how does that work? Who's all involved in that? And where are some of those costs at?
The different components, of course, we have to get the drug. The drug comes from the wholesaler. So imagine a circle and they're on the top of it, or not the wholesaler, the manufacturer. So you have the manufacturer up there. Then you have to have wholesalers, because who's going to move the drugs? So then we have our wholesalers, they're part of it. So they're kind of on one side, and then you start going down the other side. And so you have the health plans, you have the pharmacy benefit managers, you have the pharmacies down on the bottom, and under that you have the patient. So it's everything is connected together. Now, what's the dynamics in it is that as much as we want to say big pharma, and big pharma is an issue with the cost of drugs. However, we have the pharmacy benefit managers in there. Now, back when we started in 2006, the pharmacy benefit managers, this is before Medicare. So pharmacy benefit managers were controlling prescription drugs, doing the claims, doing the negotiations, and they were doing it for all the private plans, the employer plans, the retiree plans, everything but Part D, because we didn't have Part D. So when Medicare came out with Part D, they thought, oh, okay, these people are the ones with the contracts. They're the ones with the knowledge on prescription drugs. They know how to negotiate. They'll be the best people to keep the prices down, right? To drive the prices of drugs down. Well, that's how it was supposed to start. And then, of course, the pharmacy benefit managers actually showed who they really are, and they are the greed behind it all. Because unfortunately, yes, they have been going in and negotiating prices and driving the prices down for them, right? They just haven't passed it down to anybody else. So, that's the problem. And they're doing the same thing on the employer side. It gets very there. And I can't say I understand the employer side as much because I haven't had to go and get into that side as much. But I know it's the same dynamic. So the pharmacy benefit managers were the ones that are controlling literally everything. Over time, though, you've seen the consolidation, right? And then, so you have these big, very influential, very greedy pharmacy benefit managers controlling everything. And then they get gobbled up by a health plan or a pharmacy. CVS Pharmacy was the first one that went in and bought Caremark. So you had a pharmacy buying a PBM. Then, of course, now we have Aetna, right? So now you keep putting together the pieces, and now everything is lining up. So if you're now on an Aetna SilverScript plan, instead of having competition between the pharmacy benefit managers, you have Caremark, period. So now, where in the past, before Aetna and Caremark and CVS and everybody was connected vertically the way they are, they had to go in and negotiate. So the pharmacy benefit manager had to go in and negotiate and with the plans to see who's going to be their benefit manager, a pharmacy benefit manager for the year. Well, now you don't have that. So if you have Aetna, you have SilverScript, you have Caremark, period. End of story, right? You have United Healthcare, you have OptumRx, period. You have Cigna, you have Express Scripts, period. So you don't have negotiation anymore.
Right. What exactly is a pharmacy benefit manager?
That a pharmacy benefit manager was at one time, and still technically legally is, a third party that is their job. They handle the prescription drugs.
Okay.
So the health plan, like the Aetnas, Humanas, Cignas, Blue Crosses, they're very good at handling the hospital and doctor part, right? That's been their expertise. That's what they know. That's where their contracting experience is, so forth. They never had the pharmacy experience. That all lied with pharmacy benefit managers. So of course, it was a natural transition to partner with them. And there's several of them, but there's only 3 big ones, right? That's Caremark, Express Scripts, and OptumRx. Those are the three big boys, and they control over 80% of the drug market. That's a lot of power.
Absolutely.
You know?
Absolutely, it is. So in 2022, they come out with this Inflation Reduction Act, right, which includes a big emphasis on prescription drugs. The goal is obviously to reduce the Medicare beneficiaries' cost experience at the pharmacy level, right? When they're getting their scripts, they're going to reduce it. It's been working in stages, right? We're now, I think, on, I guess, like the third level of the kind of escalation of it. As we roll into 2025, it steps up to where now not only do we have a $35 cap for a month's supply of insulin, which personally I think is awesome.
Yeah.
But then now we're adding a $2,000 cap on total out-of-pocket expenses for prescriptions at the pharmacy. My understanding is that does not include the deductible. Deductible has to be satisfied first, and then beyond that, $2K. And then they're also eliminating the gap coverage next year. Is that correct?
No, the $2,000 includes that deductible.
It does include the deductible. Okay, there's been some discrepancy on that.
No, it does include the deductible, so it's not an addition. So the $2,000 max out of pocket is just that, is the max out of pocket. And the crazy thing is that, yes, they want to drive down costs, right? Come on, we gotta face the fact. It's a government. They're trying to lower the cost to Medicare. Medicare is not sustainable the way it has been being run, just like a lot of our government programs. They had, several years ago, the pharmacy benefit managers, they don't expose themselves. They're very quiet. They're in the shadows. Nobody hears from them. They don't, unless they get subpoenaed to show up in Congress, they're not showing up.
Right.
They send their lobbyists. They do all their work, right? They're not showing up. With the pharmacy benefit managers, they don't want to be exposed because they know that what they've been doing. I mean, it's nothing new. They know that they hadn't been passing down any of the rebate money. They know they haven't been trying to contain cost. Not on their part, right? Their profits, they have record profits. I mean, we're talking seriously swimming in dollars. They didn't want to be exposed. But fortunately, we have some very loud pharmacists in Ohio. And they ended up exposing, first of all, it had something to do with, if I remember correctly, it was some of the pharmacy benefit managers and the Medicaid system, right? That they got exposed to, hey, you're charging us too much. So they've been sued by the state Medicaid, a lot of them, the state Medicaid systems. And it exposed kind of, okay, wait, what do you mean? Who are these pharmacy benefit managers? So it started putting the spotlight on them. And the light's been growing ever since, because now it's kind of like, oh, these people are controlling drug costs. We kind of didn't understand the dynamics because Congress didn't understand the dynamics of the pharmaceutical market. Over that time, of course, they've become much more educated than what they were. So they realize now, wait a minute, here's a problem. It's not just big pharma, it's actually pharmacy benefit managers. And a lot of them have definitely become very loud at attacking them. To say, look, the greed has got to be reined in. So they come out with the Inflation Reduction Act, yes, to lower the cost of drugs, but look at who it lowers the cost of drugs for. It originally had a lot to do with lowering Medicare's cost of drugs.
Correct.
They have been paying 80% of the tab when somebody reaches catastrophic. Right? Technically, even more than that, because they get the pharmacy benefit managers gets to kick up what they consider pharmacy fees to them. Well, what is a pharmacy fee? It's anything they say it is. So it's they say what it is, right? And so they are Medicare has been paying a big chunk of the bill. Well, we know the rebates have not been passed down. There's absolutely no transparency in the system whatsoever. And this was a way that they could do that. And I mean, it's definitely the most significant change to Part D since the beginning.
Absolutely.
And if they're not careful, and that's why I kept saying, if they're not careful, they're going to collapse it.
Yeah.
Because Medicare, believe it or not, Part D is built only on 5 principles, and they were crumbling 3 of them. So it's like I'm sitting here thinking, okay, guys, we might not survive this, right? The not the standalone PDPs might not survive this, and I think that's what, when they started going into the bidding process, I think they recognized, oh wait, we're gonna have to adjust.
Yeah.
Because they were heading for, they were going to have to be a bailout, honestly. And so of course they come out with this stuff yesterday, and I've been still trying to go through it to figure out, okay, what exactly is happening on the inside. And you think,
Absolutely.
and this gets complicated.
Well, we're going to get into some of that, but I've got a couple more questions to catch up. You had mentioned that PBMs are driving prices down, right? But they're not passing it forward, right? They're saving themselves money. And then you made a comment about rebates not getting passed down as well. So let me see if I understand this correctly. The PBMs are negotiating the rebates with the manufacturer. They're getting the rebate, but then they're still charging full price beyond that, basically, yes. Right? And then they're adding fees on top of it.
Right. So yes, so you might get something like Humira, and Humira's price might be, I'm picking up numbers out of the air here. It might be, say, $5,000, and that might be what they're saying they're paying for it, but they're getting a rebate of 40%. Now, who's getting the savings of that 40%? Well, they're putting that 40% in their pocket, because we're still running off the average wholesale price.
Yep.
So that's where our seniors are it's still coming from there, right? So that's what they're saying they're paying for it, but they're really not, because they're getting this 40% rebate. But of course, they don't have to disclose that.
Correct.
They don't have to say how much that rebate is. They don't have to say squat. And the lack of transparency is what allows that to happen, because they don't have to disclose it. I've always said, and I've said it numerous times, you'll get a secret out of the government before you find out actually what these rebate percentages are, because they're ridiculous. They're ridiculous.
Yeah.
But then, you look at your motivation before the Inflation Reduction Act, and really before 2024, the motivation of the plan, when I say plan, I'm not talking about really the health plan, I'm talking about the pharmacy benefit managers, because they're the ones involved here. But the whole progression of the stages, that motivation was to get somebody in the gap. Because if you looked at, that chart that I've been carrying around for the last year and a half, 2 years now, showing the different colors of where their financial responsibility is. It was in the initial coverage phase that the plan paid 75% of.
Correct.
Well, they don't want to continue that. They want you in the gap, because then they go down to 5%, right? So they were motivated to get somebody into the gap. Well, what better way to get somebody into the gap than inflated prices? Right. And that's what I keep saying. The prices that we see on our estimated drug cost, they're not real, because you're not taking in consideration the rebates. It's real in the fact that that's what our math is going to come off of. Mm-hmm. But when you're trying to look at, can this person get this drug cheaper off their plan? If it's a generic, there's a lot of opportunity to actually get it cheaper off their plan. It just depends on what they say that estimated annual drug cost is. If you, excuse me, if you look at some of those, like sildenafil or generic Lunesta or any of the sleeping meds, erectile dysfunction meds, you're crazy if you have those on their plan. I don't
Right.
even put them into my system.
Yeah. Well,
Because,
most plans don't cover them, number one, from what I've seen. And if they do cover them, it's going to be super high cost.
well, with like the ED meds, the Medicare now will cover them,
Okay.
but they cover them with limits. See, there's a key
Yeah.
term, quantity limit. So they say, okay, we'll pay for 6 per month, but then the 6 per month is an inflated price. So why not go use a discount card and get it for 90-day supply for $20-$30? Why would you be limited to 6 and you're still paying a crazy amount?
Doesn't make any sense at all.
Mm-mm.
Doesn't make any sense.
Yeah.
So one of the other things that's happening next year as part of the Inflation Reduction Act, along with the $35 cap that's carrying through the $2,000 max and out of pocket, is something that you said earlier, is they're shifting the responsibility from Medicare having to shoulder and share in that cost of the drug that's getting passed down through the PBMs back to the carrier now. And if I remember correctly, carriers previously were responsible for, I believe, 15% of the cost, and now they're responsible for 60%.
No, so in catastrophic, the plans were responsible. It used to be 15%, then it went to 20% in 2024 because they picked up the 5% that the enrollee used to pay.
Okay.
Right, in 2023, 80% was Medicare. The plan was at 15% and the enrollee was 5%, right? Equaling 100%. Right. In 2024, it's Medicare's paying 80%. The plan's now paying 20% because they picked up the 5% from the enrollee from the year before. Going into 2025, Medicare is going to pay either 20% or 40% depending on the drug, right?
Okay.
Depending on what drug it is. Then you have the plans, of course, are picking up 60%, which is significant because their prices, their costs just significantly went up. Well, keep in mind, you're dealing with a very greedy segment of this industry. Their costs are not going to go up without them trying to save their profits, right?
Sure, of course.
So it's going to cause a shift. Now, we anticipated a big increase, in these PDP, standalone PDPs, because they have to. They're not getting the reinsurance as much as the MAPDs, right? There's Correct. A lot more money in an MAPD than a PDP. And that's why you see this thing yesterday does not involve the MAPDs. It's talking to the standalone PDPs.
Absolutely.
Because those are the ones on the verge of collapse if something doesn't happen.
Okay.
And so, I mean, it is what it is, right?
It is what it is. All right. So I've got about 5 items-ish that are considered possible adverse effects from the Inflation Reduction Act on prescription drug plans. Some of these we've kind of already touched on a little bit, but I want to dive into a few of them. Number 1 is the financial strain on Part D plans. And where I pulled this, I technically pulled it from ChatGPT, which knows everything, but it says rebate reductions, number 1. The Inflation Reduction Act may reduce the amount that pharmaceutical companies pay in rebates, leading to increased costs for Part D plans, and this could result in higher premiums for beneficiaries.
Well, let's dive into that a little bit, right?
Yeah.
So, with the rebates now, and this is again with the kind of like where I have to chuckle because I understand, and even some of the calls I'm on some of the calls. Last one I was on with several of the manufacturers and some of the other industry heads that I am involved with. And there was, of course, you're not going to get a PBM on one of these calls. And you could see the grin and the look in the manufacturer. I'm not going to call out which one it was, but the manufacturer, because they know they're upset because it's like, because of the greed of the pharmacy benefit managers, the manufacturers got drug into this mess, right? So, I mean, literally they've been discounting the drugs in the form of rebates.
Right.
They've been lowering the cost of drugs. It just got stalled
Just
in the
getting
middle.
chewed up in the middle.
Right. So now, of course, because the pharmacy benefit managers have chosen to sit on that money and keep it for themselves, now you have Congress involved. Now you've got people upset and mad. And now you've got the Inflation Reduction Act that's targeting both the pharmacy benefit managers and the manufacturers. So of course, it's like the manufacturers, at least what I've heard, they're estimating about a 31% decrease in their profits because of the Inflation Reduction Act. That's huge. That's huge. And it's going to have a negative rippling effect through manufacturing. And that's a whole different topic right there. Because for them to choose which drugs to invest their money in and which drugs to bring to market and where are they going to bring those to market, that is a whole different ballgame, because decisions are now going to have to be made because of the effects of the Inflation Reduction Act. So, so of course they're looking at it and they're looking at, okay, we're already taking a big cut. We were already discounting these prices, because at the end of the day, the reason the manufacturer would give a rebate is because they want their drug on formulary. That's the whole reason behind a rebate. So brand Humira will come in and give a big rebate. Now, of course, they were exclusive. They only had Humira for about 30 years because they played the patent system. So they've been the only drug on the market, but that's a biosimilar, much, much harder to make than a normal drug. But we have a lot. You think of how many drugs we've had come out since the beginning of 2024, numerous biosimilars to Humira, numerous. And they were all poised, but they couldn't bring it out. And honestly, even when they first started bringing out the biosimilars, Humira just pumped up the rebates and they blocked them out. So they weren't on anybody's formulary.
Right.
And that's how that works. So now the manufacturers are looking at the pharmacy benefit managers, who they know are going to come back and say, oh, poor us. We need more money. We need more rebate money. And it's like the looks on these people's faces, because it's like, no, you're the dummy that got us in this. I mean, if you would have passed even 50% of the rebates off that we were giving you, we wouldn't be in this mess. So yeah, they're not happy.
That you mentioned something perfectly that leads me to another thought here, and this is another possible adverse effect, is the potential for reduced drug availability. So in other words, formulary adjustments to manage costs. Part D plans might restrict their formularies, limiting the availability of certain drugs, and this could negatively impact beneficiaries who rely on specific meds. So do you believe there could certainly be a reduction in the availability of prescriptions? Okay.
They have to, because even in this ruling that it's not even a ruling, even the stuff that we got out from CMS yesterday talks about the whole aspect of cost containment, right? So instead of just paying whatever the PBMs say that, okay, you owe us X because this is your 80%, right? Or whatever your percentage is for Medicare, they're now bringing their subsidy from the back end of paying what was owed to now they're going to subsidize the plans more on the front end, which is going to mean cost containment.
Yep.
Right? Now, these pharmacy benefit managers already run very well-tuned machines. They already have everything in place. They do run extremely well and extremely tight. There's not fluff in their numbers. The problem is their profit, right? Because you're not going to go after their profit, and you're telling them to contain cost, right? Well, you can either contain cost one of two ways. You can pay more, right? The pharmacy benefit manager could come off some of this rebate money, right? And actually do the job that they were supposed to do from 2006. Or they're going to really limit the scope of coverage, right? And how do you do that? Formulary is a big one. Prior authorizations are a big one. Step therapy is huge, going to be huge going into this. And quantity limits.
Mhm.
Those are the things that are going to be ramped up, right? And ironic enough, we got an email. I'm sure everybody got it. I'm not special. From this one was from Blue Cross Blue Shield talking about their prior authorization process. So they're now
getting you prepared for it.
kind of prepare you. And what they've done is they've streamlined their process to say, oh, look at us. We've done such a good thing. We're ready for more PAs. That's not what they said, but that's what they said.
Right.
Because they've made it more streamlined and automated so doctors can go in and see real time what's happening. They know they're going to have to contain cost. They're going to do it in the form of prior authorizations in order to make adjustments. So even in their own email, they were saying that it gives us a chance to maybe suggest a different med, right? A lower costing med. Some cases, maybe a higher costing med, but maybe it's a better med, whatever it is. But prior authorizations are going to be ramped up, which is going to take more time for doctors' offices, more time for pharmacies. And it's going to definitely require our clients to be patient in starting a new med, that they might not get it immediately. They might have to wait. And so it might be delayed by a few days. Step therapy and quantity limits, those are going to be a factor too, because it's all going to be about cost containment. Medicare stipulates that other than the 6 protected drug classes, there's 6 protected drug classes that they have to cover most, right? So their formulary, you have to have most drugs. Well, what does most mean? Who defines most? Well, the pharmacy benefit managers. It means whatever they say it means, right? It literally says whatever they say it does. So most could be, well, we're covering 4 of the 7. That's most, right? That's more
4 of the 7 categories.
Four drugs, not categories, drugs.
Sorry.
Because out of every drug class, Medicare does stipulate that they have to have 2 drugs on, for every drug class, if there is 2 drugs. Some drug classes might only have one drug. And if that's the case, that drug has to be on formulary.
Right.
If there's 5 drugs in a category, excuse me, they're only required by Medicare to have 2. Well, which 2? Whichever one they want.
Whichever one the PBMs want. Whichever one they can probably get the best rebate for themselves on.
You gotcha.
It's funny. I have a newer agent that is doing great with me, and he loves to ask questions. I love him. He's super coachable. And this is a little bit of a sidestep, pardon me, but he loves to ask me why. Why does something do? Why do doctors do this? And the answer is invariably always money. I'm like, it's always about the money, brother. It's like every time you're going to ask me that question, it's going to come down to money. Yeah, absolutely. And speaking of money, if pharmaceutical companies are facing reduced revenues, then there's an idea that could also decrease their incentives to invest in new development, innovative treatments.
Absolutely. And that was touched on in this call that I was on, because this, and it's nothing currently really that we're dealing with it, but it's all about ending up on that list of negotiating drugs. So that's their fear. So they're not only having to help and pick up more of the tab of people taking meds, they also are facing the whole drug negotiation deal, right? Which is starting slow and then will ramp up over time. So they're getting slapped twice, the one side, then the other. So there's a full effect. Okay. With that, it definitely, they have to look and say, okay, where are we going to bring this drug to market? Where, meaning which country, right? And what indication do we bring if it's for more than one indication, right? Because they're going to have to maximize the amount of dollars they make on the front end. So it's not like they're going to have the longevity like they have had to make their money back. Now they have to hit it and hit it hard, because as soon as they are released and they bring that drug to the United States, it goes on this list. So they know exactly where their drugs are on this long list of, okay, these are the ones that we're negotiating. There's a list out there, and they know where they're at, and they're going to have to make as much money as they can before they get there. Because as soon as they have to negotiate with Medicare, then they know, okay, our profits are done, right?
Because they're negotiating 100 drugs, right? 10 at a time, I think.
Well, it ramps up, and I don't have the members. I know it's the first 10 right now that for this year, which of course will be in effect in 2026. Excuse me. And then it goes up in number.
Okay.
And so it's going to take several years.
Yeah, certainly.
Where some of us are going to be old before it has much of effect. But, you know, this is all going to live on past us. But it will play into the indication that they come out with, where they come out with, because this manufacturer that was on this call had said that that's going to have to be a real consideration. And people might say, well, why is our drugs cost so much here in the United States? Well, they bring them to market first to us, right? We're first in line. Well, we may not be first in line anymore.
Right. Because of the reduced
they might take it to the EU. They're going to have to look at, don't bring it to the US because you're going to end up on this list. Let's go bring it to these other countries like, you know, the EU and everybody else that can pay, you know, and then we don't have to worry about being on the negotiation with Medicare list.
Absolutely. We had a question come in from the audience. In your opinion, do you think that the effects of this might include an increase in formulary exception denials?
Oh yeah, denials, absolutely. Absolutely. Yeah, I mean, where they've been a little bit, probably compared to where they're going, they've been, you know, more lenient. Now, keep in mind, a formulary exception is not there just because you have client Barbara wants to take a brand name just because, right? It's there for those people that may have an actual serious allergy to something in the generic. Well, it wouldn't be the active ingredient, but there's a lot of fillers in drugs.
Oh yeah.
People don't realize how drugs are made. In a normal tablet, there's only a itsy bitsy part that's a drug. The rest are fillers. They, you know, so that's the dynamics of how drugs are actually broken apart and metabolized by our body. So a tablet has to be a certain hardness. It has to release the drug at a certain rate. It has to, you know, it may have to be absorbed in a certain part of the body. So all of that stuff is the dynamics. So if somebody can't take latanoprost, right, the generic of Xalatan, the eye drops, because of a filler, something that they're adding to it other than the active ingredient, then you could get an exception to take the brand name. Okay. But it's going to have to be documented and proven. Absolutely. With your doctor involved. It's not just going to be because you want it to be approved.
Absolutely. Well, I want to go ahead and jump into a little bit of what came out yesterday. And yesterday was absolute proof that everything that Norma, myself, and other people have been talking about in regards to the effects of this from a cost standpoint and hard premium dollars has come absolutely true. Everything we've said has come absolutely true, because all they've really done is they created a kind of a smoke and mirrors little magic trick where by reducing the cost at the pharmacy, all they're doing is they're moving the beneficiary's expense from the pharmacy side of the equation to now the premium side of the equation, right? They're still going to spend the money. They're just moving it over here.
I just want to clarify one thing, because, and I've seen a lot of people, because it's more complicated than that. I just don't want any confusion. So when you say lower it at the pharmacy side, then my mind goes to the Medicare prescription payment plan thing. And I just don't want agents' minds to go there yet. That's a totally separate topic
Yep.
than what we're talking about. Has nothing to do with that program. That's a program all in itself. It's its own animal. It has its own dynamics, and it has nothing, even though it was created by the Inflation Reduction Act, it has nothing to do with what we're talking about here.
Correct. Yeah. I'm just talking about the money that they hand over the counter to the pharmacist when they refill their drug. The whole goal of it was reduce that cost. But
Yeah.
because of that, we're going to see higher premiums. We've all been saying it for a couple of years. And yesterday we found out that, hey, we're all right, because CMS released a new document. I'll make sure it's in the group. You may have already seen it floating around. But basically, all of the Part D plans, standalone Part D plans, turned in their bids for how much they wanted to charge in premium dollars for their standalone Part D. And just to give you an example, the average bid rate or bid amount last year, or current year, I should say, is roughly $63. I'm trying to find the exact number in here.
It's $64.28.
There it is, 64. Of course she knows it. $64.28. In 2025, the standalone Part D bids came in, and the average premium bid was $179.45. That is almost triple the cost of what it's currently at. So in other words, barring the hustle that they threw at this yesterday, basically all of your clients who are on a Medicare Part D plan, standalone Part D plan, are basically looking at a triple in their Part D rate, their premium, not what they spend at the pharmacy. Because again, I'm saying that they're just moving the money from one side to the other. Now, however, as Norma said earlier, they are now adding, or they're moving from a back-end subsidy, because that's what they used to do. They would look at the Part D plan's experience and be like, hey, you had excessive claims. We'll help subsidize some of that based on your experience over the last year. Basically, something to that effect. Now, instead, they're taking that money and they're now front-loading that subsidy. How much are they front-loading it? Well, $142.67. That way they can keep the average premium at it's $37 and change. It's going up about $2 this year. So that's $142 on average per Part D member per month. And if you're struggling with math, there's roughly 22 million Medicare beneficiaries enrolled in a Part D plan. So that's $142.67 times 22 million people times 12 months in a year. And that's how much it's going to cost Medicare.
Yeah, that's the subsidy. Yeah.
That is just the subsidy.
They went from the subsidy in 2024 was $47.90 to the subsidy in 2025 is $142.67.
Correct.
Now you have to keep in mind that now, because Medicare is still going to be paying some of that back end stuff. They're just going to be paying a much lower percentage, either 20 or 40, right? They're pushing the stuff onto the plans. They're pushing the cost onto the plans and say, okay, this is on you because we know you're keeping too much profit, right? Not the plan, but really you're talking to the pharmacy benefit manager through the health plan.
Right, through the health, exactly.
Right? Because, at the end of the day, these standalone PDP plans are being managed by a private insurance company, not a private pharmacy benefit manager. Correct. Even though it is technically being controlled, you got that middle person in there. So Medicare is now going to provide more subsidy on the front end because they noticed, like, wait, they were going to collapse Part D. It was obvious. So now, instead of Medicare saving all this money, right? And it's like,
that's where I was headed next.
They were saying they were going to save all this money, and now they're paying it out on the front end instead of the back end. And they're saying, okay, but we're still not going to give you as much money. Now contain cost. And when they say contain cost, all of my red flags go up, because it's like those two words, contain cost, means my client and all of these seniors and all these Medicare recipients are going to be squeezed. right? Because the cost containment is going to be coming at them. So
Correct.
our clients are getting on both ends. So yeah, it's a hot mess. So, one thing I wanted to mention, somebody had there, so in our Facebook groups, and why I bother to belong to any of the groups is beyond me, because it drives me absolutely insane. And I and it's like, I'm not going to pipe in. I've tried to establish myself in this market as somebody that knows a lot of stuff. I don't know 100% of everything, but at least I understand it when it comes at me, right? But that's only because I've been in it for so many years. But when I see stuff that's incorrect, I'm not going to run around and correct this person and that person, this the other person. It's crazy. But the base beneficiary premium, and this is a discussion
Correct.
we've been having since last year. So yes, that went up $2.08, right? The base beneficiary premium. Now that was the confusing part last year, because everybody says, oh, premiums are capped at 6%. And I kept saying, no, but it's not. And then we're seeing now, no, it wasn't. That's part of the process. So the math, just so that you can kind of get your head around it, and you might have to listen to this podcast more than once. So you have the bid, the plan bid, minus the subsidy.
Yep.
Right? Plus the base beneficiary premium.
Yep.
That's how you end up with your monthly premium. Now, if your bid minus the subsidy ends up being 0 or less, right? Then the only thing you have left is the base beneficiary premium, right? But if it ends up being more, then that's when, so if you have a number higher than the one for this year, the 142.67, then you have to take that total and then plus it to the 36.78. Therefore, so for example, if you had a plan that was going to bid $200,
okay,
right? Bid 200, they're going to take the subsidy away. That's 142.67. They're going to add the 36.78. That'll end up with a premium for that plan at 94.11. That would be their plan premium. The base beneficiary premium is that 36.78. That is the component. That's why I kept saying, no, it's a piece of the equation, not actually the premium. The reason that only went up $2.08, remember, that's a law.
Right.
6% or less. It can't go higher than 6%. That's in the law.
Correct.
And that's in the law books for several years to come. So that can't go up above 6%. And so that figure is in there.
So let's have some more fun with that. Let's say WellCare wants to push out their 50-cent plan again this year, which I can't imagine they will. But let's just say they did. And they're like, hey, no, we're good. We're going to do our 50-cent plan again. Then based on this new math, what does it end up coming out to?
Their premium would end up being the base beneficiary premium.
Right. Would be the 36.78 or whatever it is. Right? Yeah.
Sure.
So, yeah, because Jason Fisher dropped a comment and he said, so does the average premium for Part D now come in at basically $100 or greater for beneficiary? That might be a tad high. I would say it's probably closer in the 70s, but yes, the rate's going up.
It all depends. Now, we have to keep in mind, this whole thing that we're talking about that came out yesterday is optional, right?
Correct. And I went through it and I couldn't find any benefit in a carrier not volunteering in it.
And I get that, except, and I was, I wake up thinking about this. I work 24/7 because my brain is constantly thinking of stuff. And this morning I'm sitting here after I woke up and it's like, and I remember I saw your comment yesterday saying, well, I don't see a reason why everybody wouldn't, but do we? Because what are they trying to do without actually making it a law? Because you keep in mind the Inflation Reduction Act is a law, right? CMS guidance is guidance.
Correct.
It's not written in the law books. They can change things. They can adjust things. A different politician can kill things, right? They can't go in and easily kill a law, but they can kill other stuff.
Absolutely.
Doesn't it sound a lot like premium capping to you?
Yeah.
So I'm just
100%, because they said they can only increase their premium from that last year or this year to next year by $35
by
max.
$35. So what starts happening, and this is hypothetical, but what
Sure.
starts happening when Medicare decides to pull back on some of the subsidy, and now they've got the cap in the premium, right? Because nobody says they're going to always subsidize. They can pull that back, and now they say, gotcha.
It's a good point.
So are they going to run to do it? I don't know. The pharmacy benefit managers, how would I look at it and it's like they're not going to want the restraints. I mean, and I can't. Well, they can come at me if they want to call me. They can call me, but I've always said that, especially with this vertical consolidation, where now you have all these health plans and pharmacies aligned with the pharmacy benefit managers. And it doesn't matter who buys who. CVS Pharmacy bought Caremark. And you would think CVS Pharmacy would have been the boss, right? They're separate companies, but they're still, the rules are coming from Caremark. Those pharmacy benefit managers would sever a limb to protect themselves. And if they have to take out the health plan or take out the pharmacy or take out the specialty pharmacy, whatever they have to take out, they're going to take them out before they come after their core.
Wow.
So how's the health plan going to move forward? Good question. How much power do you have in that conversation with the pharmacy benefit manager?
Understood. Well, we've already seen some plan exits. We had Blue KC, right? Blue Kansas City already said, we're out. Deuces. Yeah. We're not in anymore. That's 30. And that's not, people are like, oh, it's just Blue KC. They're in what? Like they had 30,000 members in one little area. Like that's going to be a big impact in that city. I don't think they'll be the last one. We'll find out for sure, I guess, as this moves forward more. But as we wind down, we got a few more minutes and we've been diving into this. We could easily do this for 2 hours. This is such a deep topic and we may need to follow up on it again later. But one of the other things that you do is that you have the RX Saver Pro University, which teaches educates agents on how to better help their clients save money on prescriptions. So before I dive into that and help you maybe promote that and how agents can get in contact with you on it, when you're talking to a client as an insurance agent and they're like, Norma, these scripts are killing me. I need this one. It's not on formulary. What is kind of like your process on how you solve that problem for that client? Like, I'm sure you have like a little bit of a step process. Let me check here. Let me check here. Let me do this. Let me do this to help that person get what they need at the cost they can afford.
Yeah. And there's a lot of dynamics in that. That's why I spend so much time actually training my member agents on how to think about things and work through things. Because there is so many dynamics and that's only getting worse, not better. But when I meet with a client, like I said, the first thing when they say, well, I'm on sildenafil or I'm on generic Lunesta or I'm on Zolpidem or whatever, and I put them, the ED meds I'm not even putting into my quoting tool. The other ones I'll put in my quoting tool just so I can see what does it look like. I always go into it thinking price of PDP. Right? So if the 50-cent plan is available, I want to target that. But then it doesn't matter if that plan doesn't fit their drug list. So if I have a person that gives me their drug list, I plug it in and that lowest cost plan is not on top, right? Meaning the lowest costing, I want to know why. So I go into the plan details and say, okay, what drug is running this up? Is it a generic? Is it a brand? Is something not on formulary? If something's not on formulary, well, then was there something else on formulary? Because with the WellCare plan, they took Humalog and Novolog off the formulary, right? Which means an agent that didn't know any better would put a client on that takes one of those onto a higher costing plan because that drug needs to be on formulary so that it's part of this insulin savings program, right?
Right.
Well, no, because there was 2 drugs on that formulary. They were Viasp and Lyjumbi. Those were the 2 drugs in that same drug class that was on that formulary that's on it today, that the client could have easily had a conversation with the doctor and said, hey, can you change me to one of these other 2? Because if you can, I can go on this low cost plan. But if you say no, I have to go on this higher cost plan. They're in the same drug class. Of course, the doctor is going to change. It doesn't matter to them.
Right.
Right. So it's like, okay, yeah, there's no clinical reason why they couldn't go to that. And so it's all about education like that, right? So there are different ways of either figuring out what's on formulary, what's not. If something's not on formulary, then is there a different way to get it? So I know all the strategies when it comes to patient assistance, grants, manufacturing cost plus or cost programs, cost plus options, online pharmacies, discount cards, the Canadian Med Store, other certified Canadian pharmacies. There's all kinds of strategies that you can use. I actually built the first and only drug savings database that encompasses all of that. So people say, and I had an agent tell me last week, well, I use Needy Meds. Well, okay, but Needy Meds will only do patient assistance and grants. And go have fun with that because time is money and you're getting ready to waste a lot of time. I literally could have told you, my database could have told you in under 15 seconds exactly how to get that drug, right? It would have told you if there was patient assistance, it would have told you the income criteria, the other criteria, it would have gave you the paper application. If there's patient assistance, it will, or not a grant, it'll tell you what grant is available. Is it opened or closed? What is the other criteria? Discount cards, like I said, cost plus, manufacturing cash discount programs. Xarelto has a manufacturing cash discount program. Brand Xarelto, or brand Synthroid does. There's several different things that do. And then we have the cost plus programs as well. And there's several more. There's even membership programs because, of course, I look at not only working with people that work with Medicare, but a lot of agents do ACA as well, right? You can use my database for ACA. You can use my database for people on short-term employer groups. I mean, the database will be expanded even to the employers because all of these saving strategies can be used by all avenues, not just some. Now, granted, there are some stipulations and criteria that might be specifically for somebody on an employer plan versus Medicare. Manufacturing discount cards cannot be used with people on Medicare. They can on people on ACA. So there's different dynamics. And that's what my database actually brings. Because my platform at the end of the day, even though it'll give you all the training and all the tools I could possibly give you to be extremely successful in helping people with drug plans, it's all about that database.
Yeah.
And I mean, I spent the last 2 days in it. And I mean, we're at, I don't know, 8,000 plus drugs. I didn't look at the exact. So, I mean, those are all different opportunities. So, I stay entrenched in that continuously.
Understood. Well, it has certainly been a pleasure. We are at the top of the hour, so I certainly got to be respectful of your time and everybody else's. We all got work to do as well.
Absolutely.
But if an agent wants to reach out to you, they want to get in touch with you, they're like, hey, I'm interested in the database. I'm interested in your Saver RX University. How do they contact you?
They can most certainly, there's a couple of different ways. You can most certainly go to strategies, 4, rxsavings.com. You can reach out through that platform to reach me as well, or you can email me at norma@yourmedicarepharmacist.com, either one.
Excellent. Cool. Perfect, man. We'll get that link in the group or in the comments for sure on this as well. The strategies for rxsavings.com. I'm sure Lily's probably already on it. Strategies for rxsavings.com. We'll get that in the comments. Thank you so much.
Well, thank you.
Truly appreciate it, man. This has been outstanding. I'm sure we'll probably do another one of these as this continues to progress and we find out more next year, because it ramps up again in 2026 a little more.
Yeah.
So we'll definitely see what's going there.
There's definitely going to be more stuff coming out, and then we still have to deal with like that prescription payment plan. There's still a lot to go on.
Absolutely. Awesome. Well, thanks again, Norma, man. Thank you guys for tuning in. As always, man, we do this on Tuesdays. We do it live. We do it at 9 a.m. And we do our best to try to bring you guys actionable material, actionable content that'll help you get out there and help more people grow your business and be a better professional. So we'll see you next time. Tuesday training. Sign up for Norma's strategies for rx.com, savings.com. Sorry.
Yeah.
And start helping more clients.
Yeah.
Awesome. Thank you again. Take it easy, guys.
Thank you.